Yeah. So yeah, a little bit 25. It's hard to believe my youngest is 25, but he is. I did find out recently that I have another grandbaby on the way. I know I just had one, but I have another one on the way, apparently.
Well,
Yeah, I think you told us
congratulations.
it's you said five and it made five, right? You're trying to see what this grandbaby a tip over the scale, right? You got four boys, four girls, something like that you was telling us last time.
I have three boys and a girl.
And then your husband got like three
Oh, yeah, 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 yeah. So this will be number nine for us.
Ooh,
girls.
congratulations.
Not due till October. We got a while, but yeah, they just keep coming.
Mm-hmm.
So
She
they
said they
just
just
keep
keep
coming.
coming.
They just keep coming. Well, with eight kids, they're going to keep coming,
Yes, yes.
but that's good. It's all good. It's all good. Well, and that's celebratory. This morning I went to, not that, one of my dearest girlfriends I worked with as a nurse for 30 years. Her husband passed away unexpectedly.
Oh
Oh,
no.
So I was at his funeral this morning. I bet there were 1,000 people there.
wow.
Yeah, yeah, yep. So kind of bittersweet today. I think we almost have everybody. Kataya, is she here yet? Let's see.
Kiki. I don't see her
I don't
yet.
see I don't see her yet. Jashas, Jaquetta, I don't see them yet.
Let me tell Toya to text her real quick. My phone upstairs.
Okay.
I'm ready to text him.
Okay.
Oh, you heard me? Oh, okay. Oh, I forgot I went on mute. Girl, you know. Okay.
How is everybody doing for a Monday of week 9?
Doing good.
Did everybody get, well, I'm going to pull up the announcement I sent. I sent you a roadmap over the weekend. Was that
Oh
helpful
yeah,
to
I
do?
got that.
Was that helpful to do all the weeks going forward, just so you have an idea of what's going
Yeah,
on?
I haven't opened it quite yet. I was studying for my PEDS one, and we had clinical Sunday, but
Okay.
yes, it is a help to have it ahead of time.
Okay.
I'll print it out when I go to school tomorrow.
Now, this week, I know it was in week 4, we had an overlap of peds and community together for exams, but I think they're spread out now. So I think you guys might have a peds exam this week.
Yeah, we had it today.
Oh, you had it today. Okay, good. How
Yeah,
was it?
it's good.
Okay. And
Good.
then communities next week.
Yeah, so that was
Hey,
perfect. It was good that they split it up like that.
Okay.
I just talked to Kiki. She said she was putting in the code and everything now to
There she
log
is.
in.
Yep, I
Okay.
got her. Yep, there she is. Thank you very much. Um, so let's go through. Let me pull it up here. Um, I want to go through that. Today, we don't have that much content to cover. And so I want to make sure we have a good understanding of this roadmap. So let me share my screen. Everybody with us? Jordan, I can't see you. Where's Jordan? Um, Alicia, you have me upside down, which is fine if you want to keep me upside down. Um, let's go through this roadmap. Okay, because we're in the thick of things now, right? We're in the thick of things for everything. I did send you an announcement. Oh, no, that's not what I wanted to do. I wanted to share. All right, can you guys see that?
Yes.
Okay. I did send you maybe Saturday morning or Friday evening the tentative schedule of HESI's. Okay. This right here, HESI master schedule, this was an attempt to start to give you guys a heads up, at least for community HESI. All right. So for those of you that haven't opened this is what, let's Let's see, where is it? Okay. So that's what it looks like so far from what I have. Okay. I haven't checked this morning, but I don't have Norfolk and I don't have Pensacola. I know I've got some Pensacola students here. I don't have those yet. Okay, so this is
I forgot the date, but I know we all agreed on 12 o'clock.
what campus?
Pensacola.
Oh, any particular day? Do you know?
Um, I can check. I can check and see because
It's March
It's on
18th.
the 18th.
okay, what they
March
said.
March 18th, Pensacola. So that is on a Monday. I'll double check that to see what's in the master calendar, but Monday the 18th at 12 o'clock. Okay. And then Norfolk, I don't think I have any Norfolk students in this class yet. So there's your tentative schedule, at least that's what I pulled off the master schedule for HESI's this is just community. Your other classes should be providing you the same kind of schedule so that you can start to get organized for week 11. Okay. I don't have anything to do with scheduling, as I explained it. I'm simply giving you a heads up. Your campuses should be reaching out to you because all these campuses are on these are on campus. Okay. So all your campuses should be reaching out to you to schedule. Okay. So any questions on that? Okay, let's go through this roadmap. All right, so this is a busy week. Okay, I think you remember me telling you early on that once we get past week 8, it gets really busy. All right, so this week we have 3 things due. Okay, we have our NCLEX, our third NCLEX due this week. We have a case study, not the one we're going to do in class, but a proper HESI case study, domestic violence and cultural competency. And then the HESI prep assignment is due Sunday. Okay. HESI prep is worth 5% of your homework grade, so do not blow that off. Okay. Not only do you need what?
I'm almost done with that. It's just a few that
good
I have to talk to you about after class.
Okay.
Okay.
It's not only worth 5% of your grade, but it's also your study guide for HESI. All right. So that needs to get completed. So those 3 things are due this week. The other thing we have this week is, and I sent it down here, exam review schedule. Okay. I sent you the final exam review schedule for exam 3 and for HESI. Professor Kershaw has changed her HESI review to a couple of days prior. So I'm going to update that later on today and I'll send that out. I think instead of Sunday, she's doing it on Thursday, but I'll send that out. That's for HESI review. So that's for next week. This week is exam 3 reviews, right? So the exam 3 reviews for this week are tomorrow. I believe Professor Ford is doing hers tomorrow, the 5th at 8 a.m. Eastern time. I'm doing mine Friday, the 8th, after my class, 11 a.m. Eastern time. And then Professor Kershaw will do hers on Sunday evening. And then those are highlighted in yellow. And then in green are the HESI reviews for next week. Okay. So this week we actually have 4 things. All right. This week we have your NCLEX, your HESI prep, and your case study. And we also have the reviews for exam 3. Okay, next week we have exam 3. Okay. And along with the exam 3, we have our HESI reviews. Okay, that's separate from class. Okay. And then next week you have your vulnerable populations project due. So a week from Sunday. So between this week and next week, you have 10% of your homework grade due. 5% for your HESI prep and 5% for your vulnerable populations. Okay. Look at this, preparing for your HESI. Review your HESI prep. Go back through the study guides that you created for each of the exams. Your weekly notes that you've taken. The weekly blueprint notes, right? Understanding what the concepts are about. Okay. Then once we get to week 11, there is no class in week 11, 0, because you're taking your HESIs. All right. But you need to remember that in week 11, I know you're taking your HESIs, but you have your last set of NCLEX assignment, NCLEX questions due. So don't forget that in week 11. Okay. At the end of week 11, I can't accept any more late work. So those of you that have been late on your NCLEXs, they're going to have to be on time for week 11. I can't accept any late work after that Sunday. Okay. My suggestion for taking the HESI is when you get your remediation packet, after you take the HESI, and I'm only going through this now. I know it's week 9, but we have an exam next week. Right. And then you go right into the HESI. So I want to take notes today. When you get your remediation packet, whenever you take, I have a lot of students, it looks like the master calendar, a lot of students are taking the HESI on Monday. All right. So you have a whole week to complete remediation, but don't wait. I would suggest you complete remediation as soon as you can. Okay. Remediation is due that Monday of week 12, the last week. No, and it can't be late. And I attached here remediation guidelines. Okay, this is in your announcement from yesterday. Okay, depending on what your score is on the HESI, here's the required hours to spend in remediation. Everybody see that? It hasn't changed from last term. Okay, so your remediation guidelines are in there. The schedule, the review schedule is in there. I didn't get it. Did you try again? Why is this thing talking to me? All right, so week 11, HESI, get your remediation done as soon as possible. Don't forget your NCLEX questions. And then week 12, let me jump back to week 11. You're taking your HESI counts for your attendance for week 11. So the fact that you take your HESI, that's your week 11 attendance. Week 12, we still have to get together. Okay, on this Monday during class time, but it's a short class. It's really to get attendance. All right. And we'll do any kind of end of term. We'll talk about the HESI. We'll talk about any questions you might have. It is a short, we're only here for 10 minutes in week 12, but you got to show up to get attendance. So if you're having issues with attendance throughout the term, you really need to show up because you don't want to miss 10 minutes of a week 12 class and get docked for a whole class and have your attendance bumped up to a certain percentage where you lose some of your grade. Does that make sense? And then once you come to class in week 12, hopefully your remediation's done, you're done. Okay. So that's your blueprint for the rest of the last 4 weeks. Does anybody have any questions about that? No. Is it helpful to have it all laid out? I know it's overwhelming, but at least you can map out what you need to do for a community.
Mm-hmm.
Does that make sense?
Yep.
Okay. I'm still missing 3 students. Keep going. Okay, any questions about that? So today I want to cover week 9 concepts, cultural impacts and human abuse and violence. I have the books pulled up. I want to point out a couple of things in each chapter. You've got your weekly notes. And then I want to break you out into 3 groups and we'll do a case study on cultural competence. We'll come back and talk about it. And then we'll be done. Does anybody have any questions about anything? No questions? Okay. All right, let me pull up. Let's see.
I'm sorry.
Oh, okay, Nina. Thank you.
You're welcome.
Oh, bummer. Okay. What about Rania? For my Richmond students, anybody know where Rania is? Rania. Okay. Like Cuyahoga, Nina, you're here. What about Deshas and Jaquetta? Do we know where they are?
I have Jaquetta's number. I could text her and
Jaquetta?
see. I think, yeah.
Jaquetta, yep. And Deshas is not here either. Okay.
Yeah.
All right,
I'll
thanks.
text her. Mhm.
I appreciate it. All right, let's do our week 9 content. Hey, can everybody see that? Okay, human abuse and violence can be difficult to talk about, right? But we have a lot of abuse and violence that goes on in the community, in our community settings. Okay. I'm going to go through the notes, but I also want to pull up the book with regards to different kinds of human abuse and violence. So when you think of human abuse and violence, what kinds of things do you think about? What do we think about?
Verbal abuse,
Mm-hmm.
physical abuse,
violence.
mental abuse.
What else? Domestic violence,
Yep.
intimate partner violence,
What is that? Wait a minute. What is intimate? Wait a minute.
intimate partner violence between a couple.
Oh, okay.
Just like it says, intimate partner violence.
Okay, I got you.
Right, human trafficking,
Oh yeah, that is abuse.
child abuse, child neglect,
Mm-hmm.
sexual assault. Right, we know that violence is a maladaptive coping mechanism. We know that violence significantly increases with the vulnerable populations, just like substance abuse. Okay. In the course of our nursing careers, we will be working with both victims of violence and perpetrators of violence. Right? We know that people who are become involved in violence have previously been exposed to some kind of violence, whether it be in the home growing up, in the workplace, in the schools, in their families. Abusers have often been beaten when they were children, or they witnessed siblings being beaten or parents being beaten. Right? Abusers typically learn that violence is a way to manage conflict. Okay, we know that high levels of violence are tied to health disparities and adverse health outcomes. We think about chronic diseases, chronic stress, physiological conditions, emotional conditions can lead to violence. Maybe obesity, diabetes, hypertension, all those chronic diseases, cancer, right? What does it mean when we say nurses are mandatory reporters of violence against children and elders? What does mandatory reporting mean?
You have to
Yeah, we must
report.
report it.
You don't have no choice if you know that it's going on. They say if you if you expect it that you have to go tell somebody.
Okay. Is this just in the workplace?
No.
We're mandatory reporters regardless of where we are. Whether we're at the playground, at the grocery store, at the rec center, at the beach, right? We are mandatory reporters. Okay, there's two types of neglect. There's physical neglect and emotional neglect. I want you to understand the difference between the two of them. We had a quiz question about physical neglect last week. Physical neglect refers to the failure to provide food, clothing, shelter, hygiene, and then our answer was in addition to medical care, right? On the other hand, emotional neglect refers to the absence of nurturing, role modeling, acceptance, caring for essential growth and development. That's neglect, emotional neglect. We know that kids who are exposed to violence, whether they're victims or whether they're witnesses, become much higher risk for mental disorders, higher risk for self-harm, higher risk for substance abuse, higher risk for suicidal ideations and actually completed suicide. I saw this all the time in the schools, working with kids for 20-something years. It was the kids who were exposed to violence had a higher risk of all of these. We know that abuse is about power and control. And all of these violent episodes are typically used as a method of control. We'll talk a little bit more about family violence when I point you to some areas in the book. But family violence is typically seen the most powerful against the least powerful. So a parent against or a guardian parent against their kids, a parent or an adult against their parents or the elders or the elderly neighbor or their elderly relative. We know that abused kids, are much more at high risk to actually perpetuate violence themselves as they get older or tolerate violence. You know, if your parents are in an abusive relationship, kids may tend to choose a partner that is also abusive. Families who live in poverty. We've talked about family living in poverty as a vulnerable population across all of our communities. Families living in poverty may also be dealing with crises within their family. Maybe an unplanned pregnancy. Maybe somebody's unemployed. Maybe they're going through a divorce, infidelity, substance abuse, neglect, domestic violence. Okay, families living in poverty or living in a very vulnerable situation are very high risk for additional crises to be going on within their family. Elder abuse. Elder abuse is a type of family violence. Whether it's abuse, neglect, maybe financial abuse. We hear those horror stories of elderly people getting scammed for all their savings, all their money, sometimes even done by family members. And then the victims, it doesn't matter where you work in the community, whether you're in a medical office building doing appointments, urgent care, long-term care facility, neighborhood clinic, you are going to be exposed to victims of violence. They may be kids. I was exposed to kids that were victims for 20 years. All right, kids will complain of certain things. You know, maybe frequent headaches, frequent stomach aches. Maybe they've regressed and are bedwetting. Increased anxiety, increased depression, withdrawn behavior, maybe promiscuous, having inappropriate sexual behavior or knowledge. Okay. One of the top risk factors for intimate partner homicide. Okay, so within a couple, homicide, they've killed the other. One of the top risk factors, previous domestic violence issues. Other factors with regards to intimate partner homicide, access to guns, estrangement from the family or the kids, threatening behavior, threaten to kill you or kill the kids or take the kids or kidnap the kids. Okay. Abused women, prone to headaches, palpitations, sleep issues, appetite issues, sexual dysfunction, maybe stress-related irritable bowel syndrome, urinary tract issues, vaginal infections. They're at higher risk. Abused women, they're at higher risk for miscarriages or preemie babies, low birth weight babies. We do know that violence, if there is a violent cycle going on, it generally escalates during pregnancy. So let's say we're working with a client, male, female, child. When you suspect any kind of abuse in an adult, what's the best way to work with them? Think back of what we've learned. This is a vulnerable population. How do we communicate with that victim of violence?
Use therapeutic communication, like open-ended things, allow them to
Exactly.
their own situation, and
Right.
then go from what they explain about their own situation.
Right. No, exactly. Thanks, Kelly. Non-judgmental, right? We don't want to assume anything. We want to give them the opportunity to tell their story. What's going on? We don't want them to feel shame. Don't want them to feel guilty. We don't want to portray it's their fault. But what if we're working and there were many, many kids that I work with in the schools that their families had a lot of violence going on within their family? Okay. When I would talk to the parents, if I came upon a parent that really didn't have anything, they lived in poverty, didn't have a lot of resources, didn't have a lot of social support, that just increases the risk of the kids living in the home. The parents would have more depression, have multiple stress factors, right? Maybe somebody didn't have a job. How are they going to put food on the table? How are they going to get their kids to school with no transportation? Elder abuse. Elder abuse is common and it's frequent. Does anybody have any experience in working in a setting where they've experienced or experienced elder or seeing elder abuse? And what did it look like?
Oh yeah, I work in a nursing home since I was like 18. Um, I think the craziest one I ever seen. Well, shit, that is kind of crazy. A person hitting a resident. I mean, yeah, that's about the craziest thing I ever seen.
You mean a
Have
staff
a
member?
financial.
A staff
Yeah.
member hit
Oh,
a
and
resident?
yes, staff member. And state got involved. They did an investigation. He got fired.
Uh-huh.
I don't know what happened after that. Then another one I seen, and this pisses me off bad. Like, mm, is I've seen not the physical part, but like people intentionally not feeding people that need to be fed. That grinds my gears. So I done laid a few people out behind that, but I've seen that. Um, I don't know. I'm 32. I've been doing this since I was 18, so I done seen a lot. It's crazy.
Sure.
I know I saw one of the one of my staff members who I used to work with, like when I first started nursing. I mean, not nursing school. When I first started being a CNA, well, I saw one of my coworkers slap one of my residents on the head, over the head. All I heard was the slap, and he was just rubbing his head, and I'm looking at the dude like, I know you did not just hit. So I went and I was a snitching. I snitched that day because you ain't finna do that.
That's
Because
not snitching.
what if that was your grandma or granddaddy or
That,
mama
yeah.
or dad? You not finna do that. And then I actually had to talk to one of my staff members again because she didn't want to work. She refused to take care of a patient because she found out about his background. It doesn't matter about his background. Like, you still got to take care of this patient. Like, come on.
Well, you bring up two good points. You weren't a snitch. You were doing your due diligence of mandatory reporting, right?
Mm-hmm.
And let's talk about the staff worker who refused to take care of a client. What was their responsibility? Let's assume that whatever it was, the reason, their personal beliefs, whatever. What's their responsibility if if they're refusing to take care of a client?
They should find somebody that is willing to take care of them. It's funny you
Exactly.
said that because I've had that situation happen. Where a few people at my last job didn't really want to take care of this one man. And his background was crazy. Like he was a child molester. He, did certain things that was
That was
crazy.
the same reason. That was the same with my patient.
Yeah, but unfortunately, at the end of the day, you still have to take care of certain people, whether you really want to or not. You know what I'm saying? Just treat them the best that you can. You ain't gotta like them, but
Mm-hmm. But let's say you, for whatever reason, you just can't do it. What's your responsibility as a nurse?
find somebody that can.
Right.
Give that person to somebody.
Mm-hmm.
When I first started with Fortis 3 years ago, it was in my probably second or third term. We were doing this discussion, and one of the students, I think it was her sister. Her sister worked in a correctional facility. She was the nurse in the correctional facility, right? She had lost her husband to murder, to violence. And the person who killed her sister's husband was in the prison.
Well, she probably got that job on purpose. So she can take his ass.
Well, what happened was she could not take care. She could not care for this person in the correctional clinic. She ended up quitting her job because I think she went to another facility, but she was unable, for personal reasons, and probably very valid, to take care of that prisoner, since they had been the one that had murdered her husband. So I only bring that up because there are situations in which, if you decide that you're just unable to provide competent nursing care, you can't abandon, right? But you have to find somebody to take over that client.
Right.
Does that make sense? I mean, just a very, very unfortunate situation.
So I worked for a corrections facility for like 6 years. But I know here in Florida, as long as you write an incident report and you submit that to the warden, they 9 times out of 10, I mean, almost every time, they have that person transferred so that you don't even have to come in contact with them.
Yeah.
Oh, that's nice. Real
And
nice.
that's good that there's that avenue. I believe she quit her job and went to another facility, but she just couldn't do it. Yeah.
Yeah, I probably couldn't either, because baby.
All right. Elders are at risk for, going back to elders, are at risk for any kind of violence, physical, emotional, financial, as well as neglect. Right? Some examples of emotional abuse of elderly: demean, affect the self-esteem, name calling, scaring people, embarrassing people, destroying property. Like Crystal said, physical violence, slapping, hitting, right? Not letting them see family or friends. Right? And then neglect, elderly neglect. And if you're out in the community doing home health visits, this is something you need to be mindful of. It's part of your assessment. Right? Are they being neglected of their basic needs? Food, housing, clothing, medical care. Are caregivers abandoning them? No longer providing care for them? Financial abuse. What if there was an old exam question about, let's say, an elderly family member's kid is now taking over all the finances, right? You have to be mindful that they're doing that appropriately, right? Is their money safe? Is their property safe? Are their assets safe? Or are they being misused? Or their accounts being drained? Elder abuse is common, and it's getting more common. Whether it's in the home, facility. Another kind of violence is suicide. It's obviously a self-directed form of violence. It's the second leading cause of deaths among young adults, 10 to 34. Some leading risk factors for suicide: depression, mental disorders, substance abuse disorders. Have they had a previous suicide attempt? Have they talked about it? Talked about a plan? Is there family history of suicide? Family history of mental disorders, substance abuse or violence, firearms in the home? Family member incarcerated? Maybe you've been exposed to suicidal thoughts or ideations of other family members. What about people who abuse animals? They're also much more likely to hurt others and themselves. Primary prevention. I just want to talk about that for a little bit. So primary prevention is prevention. So in the schools, some of the interventions I was involved with were school-based education programs that talked about, well, first screening for kids who are increased risk for violence themselves or violence against themselves, violence against others. Education programs to help them try and have more effective coping mechanisms after we identify them as at risk. We also work with parents, teaching them better parenting skills, them better coping skills. Anger management programs. We did a lot of work around anger management with the students, the teachers, and the parents. We have an excellent resource in our community that did home programs, home visits for families at risk of violence. Okay, I want to jump to the book here because I want to point out a couple of things. This is in your, what am I in? Is it your med surg? Okay. So you're responsible for reading chapter 45. Just want to point out a couple
That's
of
the
things.
foundations book.
I'm in the med surg book.
That's
Chapter
not a med surg book.
Oh, yeah, it is. Med surg nursing,
Oh, okay.
right?
Yours look different from mine.
Okay. So, care of patients with emerging conditions, trauma, and shock. Just want to go through just a couple of things. Prevention of accidents. Okay, the highlighted parts of what I'm pulling out of the chapter that I want you to be aware of. Okay, there's three kinds of safety: home safety, highway safety, and water safety. I want you to be aware of those three. Okay. And I've highlighted what I want you to be aware of. I want you to have a look at box 45.1. Okay.
Mm-hmm.
What are some home safety tips for the kitchen? And it goes through the different room. Whoops. Sorry. Goes through different areas in the house. Tips. Okay, so for the kitchen, for the storage areas, for the living room, I just want you to have a look at this. Okay, because that's part of our assessment. When we go into the home in community nursing, we do a home safety assessment. So these are some of the things to be looking for. Okay. Maybe we're working in the schools and we're working with kids that are old enough to get their licenses. So we look at highway safety, maybe teaching them the importance of wearing seat belts, not driving under the influence, discouraging the use of cell phones. And then water safety. Let's say we're working in the community and we're doing spring's coming, summer's coming, and we're doing some preventative education. We know a lot of people are going to spend times at the parks or in the streams or in the lakes or at the rec center in the pools. I've highlighted something here I'd like for you to know. Right? So let's say you come upon a victim of a diving injury. You need and you suspect a neck injury. Okay? You shouldn't remove that person from the water until EMS is there because of a possible neck or spinal cord injury. If you can, immobilize the head and the neck, trying to keep the victim's face out of the water, head out of the water. However, if the victim isn't breathing and you can't do the rescue breathing in the water, obviously you have to remove that client from the water and start your CPR on a hard surface. Okay? First aid and Good Samaritan laws. We kind of talked about what is a Good Samaritan law? What is that?
Isn't it a law that's supposed to protect you? Like, if you're a nurse or something, and somebody is hurt on the side of the road, if something happened to them or something,
and you start to work with that person, right? You are covered. You're the Good Samaritan. You stop to help, right? So it's when we're rendering any kind of emergency care, right? It guards us against liability. Okay. We didn't really go into detail, but this chapter talks about different kinds of patients that we might take care of. We might take care of a combative patient. Here's more about domestic and intimate partner violence. Remember the weekly notes that I give you, I develop a lot of those weekly notes from your book. Okay, so you do need to go back and go through this. Domestic and intimate partner violence. And through each of these sections, that if it has a box attached to it, that box questions how to detect abuse. That is specifically for domestic and intimate partner violence, if that box falls under that heading. Okay, so ways to, questions to detect abuse. Right? Have you been hit or hurt in any way in the past year? If so, who injured you? Has it occurred before? Are you afraid of anyone? Do you feel safe at home? Do you use drugs or alcohol? Okay. Another form of violence we talked about, child abuse, elder abuse. And simply, I mean, this is pretty important because the population of those over 65, that is actually the fastest growing demographic. So therefore, it's going to be an increasing demographic that's going to be subjected to neglect, abuse. Okay. And as with child abuse, the law requires that signs of elder abuse must be reported. We don't need to go through any of that. thought there was one other section I wanted to review in here. Nope. Nope. Okay. So let's go through the second concept, which is the nope. And then we'll go back to the book and talk about that. Cultural influences in nursing. This is a perfect concept to end with in everything we've covered with regards to community nursing. Cultural influences in nursing. Over the course of our nursing career, we are going to be working with dozens and dozens of different cultures. Are we not? What does it take? What should we be striving towards as nurses with regards to culture? What's that buzzword I keep talking about?
Understanding.
Cultural competence. What does cultural competence mean?
Being in control of our biases before we start taking care of a culture.
Part of it. What else?
Knowing and understanding other cultures.
Exactly.
Huh?
Can we competently care for clients of different cultures to incorporate their beliefs, values, practices? Can we incorporate that culture into their plan of care? That requires a lot. All right, we know that every culture has their own beliefs about the world. The Hispanic culture looks at world beliefs differently than the Jewish culture, than the Muslim culture, than the Vietnamese culture, the Asian culture, right? Whatever culture we belong to, we have our beliefs about life, right? We all have different, but a lot of similarities, but we have different beliefs, values, assumptions about life that usually we are socialized to growing up, right? We grow up, in a Hispanic family. We grow up in a Native American family. We grow up in a Jewish family. We grow up in a Muslim family. So a lot of these beliefs are instilled in us early on in childhood, are they not? We're all from a different culture. Different groups, different ethnic groups. They may have cultural similarities, but they're going to probably have a lot more differences than they have similarities. But we're all unique, whatever our culture is, right? We're all unique, and no one culture is more important than the other. Okay, we know that different cultural attributes or cultural makeup may include a certain language, a certain perception of touch or space. Space may be an issue of, do you want to be up in somebody's face talking to them, and that's okay? Or do you want to be at arm's length? Touch. Is it a culture that you go up and say, hey, how you doing? Give them a hug. Maybe another culture, that's not appropriate. Personal space is a big issue. Body language, eye contact. What are different cultures' perceptions of health and illness? We talked about, I think last week, about vaccinations. Some cultures do not believe in vaccinations. What are their perceptions of health? With the Native American culture, they usually have, I think they're called shamans, that they like to bring with them to appointments. That's their ritual. That's part of their culture. Cultures have different views on family structures. What does the family look like? What's the family makeup? What are their personal beliefs on reproduction, on raising kids, on parental responsibilities, childbearing? And we talked, I think, previously about time perceptions. Some cultures are focused on the past, some are focused on the present, some are focused on the future. And we talked about the pros and cons of each. Right? So as nurses, we have got to approach each patient as completely unique. All right. And we learn our client's culture in many different ways, whether it's observation, maybe in the hospital room or rehab room or long-term care facility. We learn through observations about client interactions with, say, families or visitors or staff. We learn through assessment. Part of our assessment is learning about other cultures. If we don't know, we ask. Maybe we have a coworker who's from that culture. Maybe we learn from our coworker how best to work with a certain culture. But the most important thing is we need to educate ourselves. And a lot of times our clients are going to guide us along that path, right? We can't be experts at everything. We can't be knowledgeable about every single culture we take care of. Over my 40 years in nursing, I mean, I consider myself culturally competent, but I'm still working at it. Right? It seemed like when I was in the schools for 20 plus years, every fall we started school, and we weren't assigned to schools. We were assigned to a big group of schools. We were consultants. It seemed like every fall in one of my schools, there was a different culture I had to learn, a different, a group of, let's say Muslims moved into the community, a group of Vietnamese, a group of Somali culture, a group of Hispanic culture moved into the neighborhood and their kids came to the school. I was always on the learning curve and it was great. So I can still say after 40 years, I'm still learning about cultures. My daughter married a Middle Eastern gentleman from Egypt. I knew nothing about Egyptian culture. I know a ton now. And it's really, really enlightening, with regards to parenting practices and communication and involvement of family. It's been wonderful, wonderful to learn about that culture. Okay? We can't be stereotypical. We can't have biases. We can't pass judgment. We seek to understand. Right? We seek to understand the makeup of each of our clients' culture. We seek to understand, we seek to be supportive, and I've already said this, but we seek to learn enough about the culture that we can incorporate as much as we can into their plan of care. That may be food preferences in the hospital or what the choices are when they order from food services. It may be visiting, who visits, who can visit, who cannot visit. Do they have to be a certain sex to visit? Do they have to have certain coverings when they're visiting? Who knows? Okay. Again, we talked about this last week, but working in the community with different cultures, trusted, seek out, find your team members, find your trusted community leaders who have expertise in working with certain cultures. Pardon me. Let them help guide you through how to speak with, how to understand, how to communicate certain things to certain cultures. Maintain open, objective attitude towards individuals and their cultures. Avoid seeing all cultures as alike. Be aware, again, that's self-check. Be aware of your own cultural beliefs, your own cultural biases, and avoid projecting your beliefs on others. Right? That's called cultural awareness. Being aware of our culture, our own culture, my culture. I'm speaking about me being aware of my own culture, but understanding that there are many other cultures I'm going to be talking with, working with, that I need to be culturally aware. All right. Nurses who lack cultural awareness, cultural competence, right? They're not going to do a very good job caring for their clients of different cultures, right? They're just not. So finally, I love this. I love reading through this because this is a great summary of how to develop cultural competence. Be sensitive to cultural implications during every encounter. Avoid stereotyping based on race or ethnicity. Ask clients questions, stimulate your learning about the client's culture. Avoid assumptions about nonverbal cues from clients, from unfamiliar cultures. Don't always assume that a nonverbal cue, even if it's a look or a face or a head shake, don't make assumptions. Learn about their culture. Always trying to discover new parts to different cultures. That's a priority for us when we're practicing as a nurse. Ask families about their culture. Ask kids, the client's kids. You can observe a lot. Again, don't project your culture as being morally superior or superior to others. And if their culture presents a language barrier, find an interpreter. Find somebody who can help you communicate with that client. And that interpreter may also be able to help you communicate and, pardon me, even teach you about the culture.
Miss Marvel, I want to ask a question about that. Sometimes I see questions, it may be worded differently, but I know we're supposed to get a interpreter, but I know sometimes the options may say get a pamphlet that's in their language, or sometimes it's another option. Whenever they ask that question, they may say, I know we're not supposed to get the family member to interpret or whatever, like medical things. But sometimes those questions get me like, I don't know which option to pick depending on what they may ask. So the best option would be interpreter.
Best option is an interpreter, right? Best option is interpreter if you have one, right? Because when we talked about literacy a few weeks ago, if we're having to rely on family members, and maybe that's all we have, the best option is an interpreter. But let's say there's a language barrier, but some of the family members speak a little bit of English. We don't really know their reading skills and their comprehension level, right? So we don't know how much their understanding of what we're trying to teach or what we're trying to communicate.
Miss Marva, I remember a question off the top of my head right now. So the question said that somebody arrived in the ER in triage and they were Mexican American, but they were saying something about the nurse's coworker was fluent in the language. So the options were either to get that person that was a coworker to talk to them, or it had that as an option, an interpreter and a pamphlet. So I think I end up, by being an emergent situation, I think I end up picking getting a coworker that was a Mexican American as well to talk to the person that was fluent right there instead of getting an interpreter. Like waiting on an interpreter since it was an emergency situation. So
I know
I didn't
exactly
know.
which question you're talking about. I picked to go get the interpreter, but I definitely was stuck on that one because it was like, dang, they're at the emergency room. So what do you pick?
Right.
Which
So
one?
what was the right
Uh-huh.
answer?
I don't know. I can't remember. I just remember that being
I
an
always
option.
teach that an interpreter is the best.
Okay.
What happens if it wasn't an interpreter though? Like
Yeah.
right. That's what I just
Yeah,
said.
I think it had something to do with a child. The one of the family members was there as well in that question.
I don't
Because I
know, but
remember that question.
I don't know, but I just remember that one. I think we just had an exam on that. But that is a good question that she brings up because some of the things do not have an answer always for go get an interpreter. So in that case, what do you do? Because you know
Well,
we are taught to always get an interpreter, but what
I always teach to do an interpreter first. Okay, if an interpreter's not available, maybe a coworker.
Okay.
If a coworker's not available, maybe you have to rely on the family and hope for the best. But ideally, an interpreter is the best. I mean, yes, you may have a coworker, but are they on the same floor? Do they have time? Do they, a lot of interpreters serve a sole purpose, and that's increasing the understanding and communication. Not that a coworker is not a good backup; it's a great backup. But if I had my choice of the two, I would be going for an interpreter.
Makes sense.
If you want to read more about culture, this is an excellent. This was for chapter 14 in your fundamentals book. We've already gone through what is culture. We already talked about this. Values, beliefs, assumptions about life. Right? I want to go to the I don't need to cover that, but I want to go through I want to take you to cultural competence because I think this is a really right here. Starts on page 193. This is the section I want you to read. Developing cultural competence. And we've pretty much talked about all of it, right? But I want you to reread this section. Cultural competence, according to this book.
I'm sorry, is that the same book, the MedSearch book?
Nope, now we're in the fundamentals book.
Okay.
It was you had in your fundamentals book, your assignment was chapter 3 and chapter 14. This is chapter 14. We've already covered what you need to know last week in the legal aspects. We've already covered what you need to know in chapter 3 in class. Okay? But I want to take you to this, page 193, starting in your fundamentals book. It's chapter 14. Cultural competence in review. As you can tell, I'm a big, not stickler, but I love to talk about cultural competence because this is something that we practice and strive to achieve our whole nursing career. This isn't in your next job. This is throughout your whole career. Cultural competence, examining your own values, examining your own attitudes, examining your own beliefs, examining your own biases or prejudices, if there are any. Trying to keep an open mind and trying to see the world from a different cultural perspective. That sums it up right there. That highlighted sentence in yellow. Okay. And then it talks about barriers. We have talked about these, but this lays it out in more detail. Whoops, what did I just do here? Stereotypes, some barriers. Okay, so think about maybe people that you work with. We've talked about the the older employee who's been there for 30 years that doesn't want to do things any differently, right? Everybody gets cared for the same. Doesn't matter what their culture is. Okay, some barriers to cultural competence, stereotyping, right? You make assumptions, right? You make assumptions about beliefs or behaviors without even doing an assessment of what the individual cultural needs are. That's stereotyping. And we have prejudice, ethnocentrism. That's believing that that's my culture is better than your culture. My cultural group has higher standards than your cultural group. Cultural conflict. Cultural conflict will arise when you're working with a client from a different culture, and maybe there's a misunderstanding of something about their culture. That's the fancy name is cultural conflict. Right? You can't respond appropriately to their needs because of your lack of understanding about their culture. That's cultural conflict. And then cultural shock takes cultural conflict to the highest level. You feel helpless, you're uncomfortable when you're trying to understand or adapt or incorporate certain cultural beliefs into the care. That culture's beliefs and values are so radically different from what you believe. That's really cultural shock, and really you probably don't even have the ability at that point to care competently for that client, right? Does that make sense? Let's see. We talked about cultural differences. Communication may be different, view of time, personal space, family and social organizations. Activities may be different, nutritional practices, maybe issues related to end of care, and healthcare beliefs. Had an example last summer, Tom's mom was in hospice. She got dementia. She had dementia and seemed to be just kind of cruising along, and she had a fall. She was at home being taken care of by a group of nurses from the Philippines. They were all related. They were cousins. There were like 4 of them. And they kind of travel in a group to take care of, and one of Tom's brothers had heard about this group of ladies because they care for one of his brother's friend's parents or something. I'm just giving you an example. Well, Tom's mom fell going from the bed to the commode, and that fell just sent her into the tailspin, into that end of life. Okay, real end of life, put in hospice, whatever. Well, one of the goals of hospice is to keep clients comfortable, right? As much as you can. Well, one of the cultural issues that the family ran into is part of their culture was not giving morphine. That the culture was to let the natural progression of death happen naturally, right? So in order to maintain her comfort, Tom and his 5 brothers really had to go out and find a new care group to care for their mom, because they had to respect the culture of the current caregivers, which was not to give her any kind of morphine. So it was tough, but we had to respect their cultural beliefs. Does that make sense?
Mm-hmm.
I mean, that was a real world example of respecting others' cultures. And since they wanted their mom to be comfortable, part of that comfort was morphine. And so the six brothers had to make a conscious attempt to provide their mom with the pain relief that she needed. Okay. Here's an interesting table 14.3. If you want to review different cultural values, beliefs, and practices amongst very popular cultures, Asian Americans, Hispanic Americans, African Americans, Indians, European Americans, Arab Americans. We don't have to go through this, but have a look at all the different cultural values, practices, and beliefs from these six cultures. I think that was it. That's all I wanted to cover. Okay. Questions? All right, let me you guys pull out your case study. It was in your announcement this weekend. I'm going to start assigning you guys to rooms 1, 2, and 3. Room 1 has question in the I think the case study is on cultural competence. We'll spend a few minutes, maybe 5 minutes, 7 minutes in your room. Room 1 is question 1. Room 2 is question 2. Room 3 is question 3 of this case study. So somebody's got to have that case study pulled up. Okay. I'm just assigning as I go. Okay. Hey. Okay. I'll see you in a minute. I think you'll like this case study. Just makes you think a little bit more. Jatarius, you want to join your group? Kylie, do you want to jump into your group? Kylie, did you get an invitation for, you're in group 3?
The negative.
The public health nurse providing services to recent immigrants should be most concerned about which of the following. Okay, so if she provided services to the recent immigrants, so let's look at this. The public
It's not indicating that she's using an interpreter, maybe.
I don't know. D, if that's the one that's saying something doesn't care. It just it's the way how that one worded. I don't know. But we don't worry about costs. And it is required by
You guys done?
Yeah.
All right. My two other groups are still working on it, so give me about maybe 2 or 3 more minutes and we'll all come back into the main room.
Okay.
All right?
Okay.
You turn the TV back on, baby? Aaron, did you turn the TV back on? What? Or was that one of your brothers and sisters' TVs? Extremely loud.
And we the first ones, y'all.
I know. We always the first ones, though. I know for sure. Me and you be in the group all the time.
All the time.
Yush.
Miss Marvel, you had us over there wrecking our brain with number one.
No, the discussions I heard were awesome. That's great.
Oh, girl, you heard my cousin. Sorry.
It's awesome. Good job. Proud of you guys. You know, it breaks it up a little bit so you don't have to listen to me talk for an hour and a half. But I think it's a good case study.
Yeah, it was.
Reinforcing cultural competence. All right. I'm going to share my screen.
We sure had a reason for all along.
We did.
Okay.
We right. Ready though.
So
we said B. Well, okay, so first hold on, wait a minute. Oh, we was
right. Okay, so everybody's
okay. The rationale is nurses need to know if there are specific facts okay, for giving immigrants population, for example. Okay. All right.
Is that what you were talking about? So
yes.
Exactly. Being knowledgeable about what kind of risk diseases also the population. So the answer is B. Nurses need to know also about cultures, which we didn't really talk about in class, but specific risk factors for any given immigrant population. And it gives you some examples. Southeast Asians are often at risk for hepatitis B. They're at risk for TB, intestinal parasites, visual, hearing, dental problems. Right?
I get it, because their culture is so different. Like, so different.
Exactly.
Their medical treatment is different as well. Baby.
So when we're working with immigrant populations, as we just talked about in class, we have to consider how our own background, beliefs, and knowledge may be significantly different from those of the people we're caring for. Right? Language barriers may interfere with efforts to provide assistance. Right? Nurses, we need to understand some of the non-traditional healing practices as well. Okay? Group 2. How'd you do?
Pretty good.
What'd you come up with?
We had first came up with A, B, and E.
Okay.
Because we figured if she speaks English and Chinese, she still would need, and this particular group of immigrants speak Laotian. She would need an interpreter. It's one of the things that you would use when dealing with
right, but look at A. The nurse is already providing educational materials in English and Chinese. So that's why A is incorrect. So because they're already providing something.
So she should if she was going to provide anything, it should have been in their language.
Correct. Right.
Okay.
So the correct answers are B and E. So
okay, so that's what we had.
Yeah,
A,
great.
B, and E. So
Awesome. Culturally
okay.
in review, culturally competent nurses function effectively when caring for clients of other cultures, right? That's what culturally competent care is. We are able to provide effective care when dealing with clients of other cultures. Nurses who strive to be culturally competent respect people from other cultures. We value diversity. This helps us in providing more responsive care in tune with their culture, right? As a review, cultural competence, and I'm here, cultural competence includes acknowledging the fundamental differences in ways the clients and families respond to illness, maybe respond to treatment. Okay. We talked about this a little while ago. Maybe there's different dietary practices. Maybe there's different, I brought up the example of different approaches to pain management, death and dying, modesty, eye contact, closeness, touching. Group 3, what did you come up with? What's the right answer?
We came up with D.
That's awesome. Cultural knowledge. Right? So she is attending some kind of a local Laotian cultural center activity. She wants to learn, this is a nurse, she wants to learn more about customs and practices within that community. So she is trying to improve her cultural knowledge. And I really like this rationale as well to reinforce everything we've been talking about. Cultural knowledge is information about organizational elements of diverse cultures and ethnic groups. Okay, that's the fancy organizational elements. It's a fancy way of saying values, beliefs, practices. What is their culture about? Right? So if we have an emphasis as nurses focusing on learning about the client's worldviews from whatever their cultural perspective is, that's a good thing. Right? The more we have the better we have an understanding of the client's culture, decreases those misinterpretations or misapplication, right, of putting in place a healthcare plan. Cultural desire refers to our motivation. What's our desire, right? What's our motivation to provide culturally competent care? Cultural skill. So this is just giving a little definition of what each of those are. Desire is our motivation to learn about the skill. You're in a hurry, maybe they let something traceable. Right? Or desires our motivation to learn about the culture. Cultural skill. That's our learning to provide culturally competent care. Right? Learning about the culture, learning in the knowledge of the culture. And then cultural awareness, looks like your trap worked, is the self-examination and in-depth exploration of our own beliefs. Culturally aware. We have to be culturally aware of our own beliefs. And then knowledge is exactly what this nurse is doing. She's trying to gain knowledge and out there attending a cultural event in this particular client's culture to learn more about it. That's cultural knowledge. What do I have to mute? I don't know where all that background noise is coming from. I'm just going to try and mute. You can come off mute if you need to. But anyway, did you like that? I like that. I really like that case study. Just reinforces everything we just learned. We've already all had experience with different cultures, right? We already have. And it's a lifelong learning process throughout your whole career. Learn. Be motivated to learn about different cultures. I have a lifelong of learning about so many different cultures. It's been wonderful. So, okay. 4 minutes early. If we're going to get out 10 minutes early, which would be 4:40. So that concludes all of our content for this class. See if you can attend a review this week. I'll send the recording. When I send the recording for this class, I'll also send the extended version of the case study because the rationales have good learning in it, good reinforcements in it. So I'll send that as well. See if you can get to a review. If you can't, please watch the recordings. Okay. I know a lot of you watched my recordings last time because my YouTube video had almost 300 views. So that's great. And most of you guys did awesome on exam 2. So keep up the good work. I know it's getting busy, but we're in the home stretch. I'm here to support you any way I can. So you know where to find me. Reach out if you need anything, any support with exam 3 prep or tutoring or whatever you need. Okay, you got this. You got this. Okay, I hope you guys have a good rest of the week. Reach out if you need anything, and we'll see you next Monday.
Okay. All right. Have a good week, Miss Marvel.
Thank you. Thank you. You guys too.